So, Sajan brother, with immense pride and pleasure, I welcome you for today's session and hand it over to you.
Once again, good evening to all. Thank you for the wonderful introduction, Sri Prema. So, welcome everyone to my session. So, today I am going to introduce not a new topic. We are all medical from the side of the medical profession. So, we know about the type of wound and wound management, how it will be going on. All those things we know. Actually, it's not a new thing for us. But basically, in palliative care, as we are all know, we covering all domains of such like suffering. But majority of the physical suffering we are managing, not only the pain, other sufferings also. So unfortunately, I am also experiencing so many patients, or majority of the patients in palliative care had undergone with the suffering of so many type of wounds. So in this topic, I wish to cover two type of wound. So many types of wounds are there: surgical wound, burns type, or venous ulcer. So many type of wounds are there. Accidental injury. So today I am going to cover two main wound, basically seeing in the palliative care. So my intention at the end of the session, you need to identify the various type of wound basically seeing in the palliative care. I will explain the stage appropriate nursing intervention, which are all things needed in on stage. You able to apply comfort focused wound management principles, recognize psychosocial psychological distress related to the basically fungating wound, especially how we will provide the compassionate, dignity-based holistic care. These are all things actually we needed to cover in this topic. So, as I mentioned today about the pressure sore and the fungating wound, both I am going to cover. So, first of all, pressure sore. Nowadays, we calling it as a pressure injury. The pressure sore, why we calling it as an injury means an injury is an accidentally it's going to happen, not maybe as like infectious only. Here also, it's a preventable thing, but in some cases, pressure injury, sore is generalizing as an injury, is localized injury to the skin, and maybe underlying tissues also affecting. Usually, it's happening on a over a bony prominence area as a result of prolonged unrelieved pressure getting on certain area. As like this wound, you might be seeing. So here we have a picture. We can make a pathophysiology. Simply, I am making a pathophysiology here. Actually, here on patient is lying in a supine position for a long time. So maybe more than hours, or maybe without position changing, he is being in major time, basically, example in 24 hours, majority time, more than 20 hours or more than that, patient is lying in the same position. So we can consider here the complete body weight as a bone weight. So total skeletal system is covering with the muscles, soft tissues, skin layers, and everything. So complete body is resting on the mattress. So we can consider the total skeletal bone weight is compressing downward. Our total body is lying on the mattress. So in between, actually, the soft part of the skin, muscle, tissues, and all everything is getting compressed. So because of the collapsing of the blood vessels, which are all going through this area, actually because of the collapsing, actual nutritious content, oxygen, and everything is not at all getting to the tissues adequately. Because of that, tissue become ischemic, related with the hypoxia, and at last the cells becoming dead. So dead cells actually the covering the skin, everything because of the stress and the tension, it will break down, opening up. So actually the superficial skin only once it's lost. So gradually, as a progression wise, in depth the wound it will go. So we can see some of the risk factors or which are all the category patient actually the pressure sore development chance is very high. So some risk factors include friction or shear. Both are around same, but friction, as we are all know, opposite direction, two surfaces moving in between on force is developing. Same way, example on this same I am repeating, one patient is lying in a supine position. Suppose we needed to just move the patient from the foot end to the maximum to the head end. Suppose without knowledge, the nurse or maybe the caregiver who are all taking care of the patient, suppose pulling the bed sheet in upward, in little bit obvious patient or heavy patient means the bed sheet only will move, patient will be lying on the same position actually. So there actually it's happening, the moving of bed sheet actually just making a friction force on the back of the body of the patient. So in addition to that, suppose we making the patient in a semi-fallow position or head and elevated position because of the breathing difficulty or maybe for the feeding purpose, anything. Continuously we making the patient in a semi-fallow or head and elevated position means here actually the upper body weight according to the gravitational force completely compressing on the buttocks region. Plus in some cases actually with the head and elevated position means also some patients knees are flexed and just moving to the foot end of the bed. So here actually the friction also happening. In addition to that, the compression force also happening. So upper body weight completely the weight bearing on the buttocks area plus patient is moving to the downward. So that is the shear actually happening. So these are all some of the factors. In addition to that, already the patient is having the sensory impairment because example the patient is after a spinal cord injury the patient is becoming in a paraplegic stage, so the lower extremity is having no mobility, fully paralyzed. So the patient know actually his lower extremities are not at all moving, but he is not able because having no sensation over the lower extremity. So without the sensation patient is being in the same situation. Same way, the impaired physical mobility, already the existing physical mobility related, or maybe the patient is becoming an unconscious stage, or maybe altered conscious level, basically in palliative care related with the end of life stage, or the patient condition is deteriorating, patient is in an end of life stage. Most of all the time, patient is having no conscious level being in the same position. These are all some of the risk factors. In addition to that, complete soiling or completely wetting in stool or urine, actually. The incontinence only is the reason. So maybe the urinary incontinence related with any spinal cord injury or maybe in the geriatric population. So because of the complete wetting of the fecal matter or the urine on their skin actually resulting in the skin peeling, the chance is very high. Then proper nutrition and hydration is very very important for the skin health because of the nutritional deficit, or maybe the patient is not able to take anything by orally because of his health condition, maybe in progression of disease base, or a patient is refusing, or any other disease condition related, the patient is not at all taking proper hydration and nutrition means also it will affect the skin health and the skin peeling chance is very high. Then excessive sweating cases, especially geriatric population. These are all some of the risk factors or some category people actually the more chance for the skin peeling and the development of the pressure sore. So these are all some of the common signs we can expect the skin peeling or the development of the pressure sore. If the patient is in this picture, you can see if one patient is lying in a supine position or right or left lateral position or head and elevated position or maybe wheelchair bound stage. So in every positions, which are all the bony prominence area or which are all the areas or more prone for the development of the pressure sore. Already I marked in red mark. So these areas are all the vulnerable areas actually need special attention for the prevention of the development of the pressure sore. So these are all the some of the real pictures. So again, I am repeating, supine position means which are all the area actually, head, shoulder, elbow, buttocks, heel, both I am telling. These are all the areas actually the chance is very high. Sideline position, right or left. Left means correspondent side, the ear, outer ear, earlobe, then ribs, greater trochanter region, then knee, actually hip, heel, lateral aspect, ankle, lateral aspect. These are all the areas actually more prone for the development of the pressure sore. In semi-fowler or the head and elevated position means again these areas actually having the more prone for the development of the pressure sore. So we can consider the supine prone position also as like supine, because example, once the pressure solved already the patient is existing. If suppose we planning for the plastic surgery for the curative side of the pressure sore, we did because of the resting period. We needed to make him as a prone position for a while. So again, the chance is very high. These areas actually development of the pressure. So even we are keeping in a prone position. Actually, we making because for getting rest for the back area. Actually, again, the chance is very high in the prone area also. So actually, I have a question. How many stages are there for our pressure sore? You can put your answers in chat box even also. How many stages? Okay, on answer got us 4. All are agreeing with that or any other opinions? Okay, thank you for your response. We can see, just go through this. First one, stage 1. This one is the stage 1 actually. There is a no skin breakdown. We will call it as a non-blanchable erythema, just only the color change. Pinkish color or any brownish color change, only the color change only, blackish color change, anything the color change only, but no skin will peel off. This is the first stage. In this stage itself, this one is we can consider as a warning sign. Actually, from here we suppose we are giving proper care means we can prevent the further proceedings to the stage 2, 3 like that. So this one is the stage 2. Stage 2, we can call it as a partial thickness skin loss only. In depth, it will not go. No other underlying tissues, nothing is affected. Only the skin will peel off. One more thing, blister. Blister formation also we are considering in the stage 2. Why? Because at any time we can expect the blister, it will open. So the blister formation and the partial thickness skin loss we are considering as a stage 2. This one is the stage 3. We will call it as a full thickness ulcer. Not only the superficial skin, in-depth some tissues are all affected, but muscle, tendon, bone, nothing it can be visible. Only the full thickness tissues only affected. One more, tunneling also we are considering in the stage 3. Tunneling, whichever the clockwise direction means also the tunneling, we directly we can't conclude this much in depth it will go. So this tunneling also we need to assess further. So we are considering the tunneling also in the stage 3. This one is the stage 3. This one is the stage 4. Complete exposed muscle, bone, tendon, everything. This one is the stage 4. So in this stage, from the third stage itself, we can expect the slough formation, thick pus collection will be there, highly infectious signs as like everything may will be there. Along with that, foul smell also will be there in this stage. So up to here, you are all agreed with the total stage 4. So up to here, actually, we are considering as a progression phase from stage 1 to 1 to 2, 3, 4. Progression wise, actually, we telling it as a total stage 4. But some more stages also we added. Another one is stage 5 or unstageable. We naming it as a unstageable. Unstageable means in this picture you can see one black slough is covering on the wound bed. Actually, we calling it as a eschar. So Eshkar actually two types are there. In first picture you can see this one is a Eshkar is covering on the sacral area pressure sore is affected for a around 80 years old man or more than 80 years old man. So here according to our assessment we can understand this Eshkar is a very much dried form. If suppose we tapping means also tuck tuck on sound we can hear, not no any inflammatory sign is there, not as a wet form, only the dried form of Eshkar. Consider their age and health status, no need to suffer more. So we are leaving the Eshkar like that. We can consider this one is a protective layer. But second one is not like that. Highly infectious, pus discharge is there. Maybe patient is having systemic infection sign also will be there, or maybe high exudate and foul smell also will be there. It's second one type of Eshka we needed to remove. Then only we can identify actual the wound is in a which stage. Maybe majority thing is in as like a fourth stage, or maybe even third stage also covering by the Eshka. Actually, the Eshkar is a difficult situation for absorbing the medicines, whichever thing, as a ointment, everything we are applying means it will not absorb by the wound actually, wound cells. So here this Eshkar surgically, as like manually or chemically, we needed to remove. Then only we can proceed further wound management. So this one is we numbering as a stage 5, naming it as a unstageable. Recently, we added one more stage actually, deep tissue pressure injury, number wise stage 6. So this deep tissue pressure injury means actually this thing actually happening because of the shear force. In initially the risk factors I just mentioned as the shear along with the friction is one of the major risk factor. Here actually how it happened means here also the non blanchable only. The skin not at all open actually, but in-depth tissues are all affected. Example, the patient we are keeping in a semi-fowler position, the compression force on both buttocks area plus patient is drooling down. So here actually in-depth tissues, maybe stage 3 or stage 5 like that much more tissues are all affected. Maybe it's at any time it will open, maybe it exceed us like stage 3 or stage 5, but now the current scenario skin not at all open. This one is the stage 6 or deep tissue pressure injury. These are all the preventable thing only. So as like a doctor or nurse, whenever we are seeing these type of bed bound patient or these type of wheelchair bound patient means we need to assess. First one, we need to assess every bony prominent area or the pressure point. I already just shown in that images in supine and lateral position, whichever the area actually highest prone area. I already marked in a red mark. So those areas we need to assess. Any color change, anything is there or not, any skin peeling, any warning sign is there or not, we need to assess. Then already existing the wound means if the patient is reporting any pain or anything is there or not, we need to assess. Then we need to assess the location. We need to assess the wound around the about the diameter of the wound depth, or in addition to that any exudate is there or not, exudate color, foul smell, any bleeding or anything is there or not, we need to assess. In addition to that, any tunneling is there or not, anything means we need to mark it in our us like finding, we need to chart it. So management. First of all, in palliative care, we focusing pain and other symptom management actually. So always we need to address the pain. So we need to give the proper pain medication. Then only we can start our wound management. So stage 1, actually stage 1 I already told, only the color change, warning sign only, no skin peeling, nothing it will happen. So here actually needed best one is the caregiver education because a health professional not at all will be there for a long time. So we need to educate for prevention. We need to educate the caregiver to turn. position changing. Every second hourly, they need to change the position. In addition to that, any incontinence, bowel or bladder, incontinence means we need to address the issue. If suppose the bladder incontinence, every bladder incontinence may be not at all the catheterization, only the management. Anything is correctable. Anything is there means we can do, or otherwise we have the history, only the catheterization is needed. As like management means do the catheterization. Not only the indwelling, maybe it's according to the scenario. Not only the indwelling, maybe the urocondom for the male, or this one, anything. In such way, we need to control the incontinence, bowel and the bladder. Second one, in this one, stage one, actually, the position changing plus we can educate them to apply petroleum jelly or biolin or liquid paraffin. These type of very cheapest emollients are available, moisturizer as applicable things. Actually, they can use it for apply over the area, not only the color changed area. Especially, I am telling for the stage one. In addition to that, bed bound patient means as a part of the skin care after the sponge bath. Actually, they can nicely apply this biolin or petroleum jelly or the liquid paraffin on majority of the back part of the body. Stage 2, actually just the skin peeled off, but in the nothing it will go. So normal saline they can use it for the wound cleaning. After cleaning, actually natural wound healing we need to ensure. So here actually again position change is mandatory. So in every step it's mandatory thing only. In addition to that, after by using the normal saline cleaning, they can apply the petroleum jelly or the biolin. They can apply over the wound. Suppose any antibacterial activity, anything they need, it means only the muprosin or T-bact ointment they can apply, or otherwise biolin only is mandatory, because actually here the one moisturizing medium only we promoting. Actually the wound healing naturally it will go on. Third stage from the third stage, actually third stage, fourth or unstageable, fifth, actually three stages I am covering both. If the slough is there means we can do the surgical debridement as like mechanical, or otherwise we can do chemical debridement also. So for the chemical debridement, ideally so many ointments are available, but in our setting we are using papinuria content debridase. Debridase ointment we can apply over the slough area, so it will easily detach the slough from the wound bed. So like that way we can use it. This actually debridase we can apply in stage 3 or stage 4 actually. But in unstageable, stage 5 means the eschar is covering a thick slough only. So there actually again surgical debridement is possible, means can do, but in majority of the cases actually in our setting also we are experiencing so many patients, families are all not willing to being in the hospital for the slough cutting and all those things, or maybe patient refusing. In such situation we can nicely we can do as like thick biolin dressing, thick petroleum jelly or thick biolin we can apply over the eschar. This black eschar, on that we can apply 2 to 3 days by BD basis dressing itself, it will detach very effectively. Then we can easily cut off from this area. Again, once the eschar is removed, then we can continue by using the debridase ointment or papinuria contained ointment we can apply. So in this actually the once the in debridase, after applying the debridase, the slough is removed, good granulated tissue is coming, means we can apply the nano silver content mega heal type of ointments we can apply for the granulation improvement. Once the in-depth is covering in superficial skin layer, the granulation is occur, means we can continue by using a plain liquid paraffin or biolin dressing, or we can cover by using a plain dressing pad. So in addition to that, malodor for the foul smell management. So if the wound, majority of the stage 4 wound means severe foul smell, that much foul smell will be there, then we can apply the charcoal for the foul smell management. How we will do means charcoal pieces we can keep inside the patient room near to the bed. In any vessel we can keep some pieces of charcoal. We can keep it. In addition to that, charcoal dressing pads also available. So charcoal dressing pad, it's very costly. It's affordable means patient can use this charcoal dressing pad. It will resolve the issue for the foul smell. In addition to that, one more point I am telling, the usage of hydrogen peroxide or betadine, powdered iodine solution, nothing is mandatory for the pressure sore management. Actually, normal saline or homemade saline only is enough for the wound cleaning. Actually, these type of hypochlorite solutions, nothing is needed for the wound cleaning. It will not improve the granulation. It will affect the granulation improvement. So we are using only the normal saline or the homemade saline preparation. We will actually educate to the caregiver how we can prepare and all those things. Then they are preparing the homemade saline, and by using the homemade saline, actually they cleaning the wound. In addition to that, at any point of time, the any surgical intervention is needed means we can proceed, we can facilitate, or otherwise we can do as like this. I already explained in which in on stage how we can do. In addition to that, negative pressure wound therapy. So this management actually we are also doing, but under the supervision or under the guidance of the plastic surgeon only. For every wound, it's not at all we can do. In my experience, I did for a I think on pressure sore management only. So this negative pressure wound therapy is having a special device, but we used by using a suction apparatus actually with minimal pressure. I think 100 or less than 100 pressure we actually made and done for the wound healing. Actually, it will suck and it will improve the blood supply over the wound. In addition to that, because of this negative pressure wound therapy, actually it's suctioning the high exudate from the wound. Also, it's suctioning from the wound. Actually, in both way, we can improve the granulation and we can improve the wound healing. Actually. So homemade saline, I'm introducing only the homemade saline. Homemade saline preparation. So only we can take 500 ml of water. We can add 1 teaspoon of common salt. Boil it very well. After cooling down, they can store in a clean closed container. This NS they can use it for the wound cleaning actually. So dressing pad actually nowadays our traditional dressing pads are all available. We are all getting. I think majority of nearby PHC also providing the gauze and cotton rolls actually. So as like a traditional dressing pad, we are all using in our hospital setting. Same way we can educate the caregiver how they can prepare the dressing pad. But in some remote areas or some rural areas, actually they are not at all getting adequate dressing items means they can use their old cotton saris or dhoti, cotton piece, cotton piece clothes after washing, after proper cleaning, after drying, they can keep it these cotton pieces or the traditional dressing pad. How we are educating like that, if they are preparing means also they can keep it in a idli cooker. Actually, they can steam it for half an hour to 1 hour. After complete steaming, they can keep this dressing pad. As like autoclaving, I am actually we are educated them, but not proper autoclaving. But how much in clean they can use means also they can use. So we ideally telling this way they can prepare the dressing pad and they can use it. So they can apply if the Vaseline means biolin, petroleum jelly or liquid paraffin suppose is needed means after steaming this on the dressing pad they can apply and they can use it over the wound actually. So here how we can prevent the bed sore. Some points I am just mentioning. First one is the mandatory thing, position change. 2 to 3 hourly, but ideally we are all practicing as every 2 hourly, we are changing the position for the bedbound patient. We are educated to the caregiver also. In addition to that, if one patient is in a wheelchair bound means, example, if once the rehabilitation is started, paraplegic patient, after the rehabilitation, they are all much more trained in the shifting, how from the bed to wheelchair and wheelchair to bed. And so we are independently making them to do the position shifting from the wheelchair to bed and bed to wheelchair. Once it's attained means the family member, maybe now his wife or her husband actually needed to go to the works for the breadwinning for the family. So this patient actually total daytime they are spending in the wheelchair only. So we can tell him as a wheelchair bound patient. More than 8 hours or 9 hours, he is continuously sitting in the wheelchair. I already shown that image in wheelchair bound stage, whichever the area the most prone for the development of the pressure sore. Those areas actually needed some rest in between. So ideally, we will train them to every 15 to 20 minutes, they need to change the position. So every 15 to 20 minutes, bed to wheelchair, wheelchair to bed, not possible. So how we are training them means hold their both hand on the handrest of the wheelchair, then they can lift their body. So how much hand strength that should be there, or how much the breath holding capacity they are having, in according to that, that they can lift complete body in both hand and they can keep it for a while. They can count 1 2 3 like that in their mind and hold their whole body in air on with the support of the both hand. So in between they are doing means these areas are all getting some rest for a while, for at least for a seconds. So this way actually they can prevent the pressure sore development, especially for the wheelchair bound patient. So again, I'm repeating, manage incontinence, bowel and bladder incontinence we need to manage. Then special surface or some comfortable devices we can suggest. One is the alpha bed or air mattress or air bed we can suggest. Then water mattress or pillows and cushions. Pillows and cushions actually we are trying them to understand for using for supporting them. Example, in some patient caregiver is complaining, they are all making the patient in a left or right lateral position. After a few minutes or after a 5 minute, patient again coming to the supine position, not at all maintaining the lateral position. Actually, those positions actually they needed proper pillow or cushion support in their back. If not at all giving the support means truly the patient will come back to the comfortable position. Every patient or every person, the comfortable position, majority supine position only. So they will come back. So we need to educate them how the pillows and cushions actually need to use in maintaining their position. So in addition to that, air mattress. In nowadays, everybody knows once the patient is becoming in bedbound means they will actually search for getting off the air bed. Their knowledge actually, if suppose they making the patient lying on the air bed means no bed sore it will develop. So that point actually truly wrong. We need to tell this one is the risk factor lessening thing only actually. Actually, the airbud, actually this device is using for reducing the risk of the development of the pressure sore, not at all a preventable thing. So we need to educate to the caregiver and patient, even the patient is lying in airbed or in the water bed or normal mattress, or even the patient is lying in a floor or a hard surface means also they need to change the position every second hourly, or otherwise wherever means also the pressure sore it will develop. So the time duration may it will change. Normal mattress maybe it will develop after 2 weeks. Airbud means maybe develop after 3 weeks. That's only that thing we need to convey because we are experiencing like that. That's why repeatedly I am telling. Then proper nutrition hydration is very much important. If the patient is able to take, especially paraplegic patients, especially I'm telling, if the patient is able to take means highly nutritious food and hydration we can improve. Then exercise also we can improve. Then as a part of the skin care, back care, we can apply liquid paraffin or white petroleum jelly or biolin. We can apply over the back area and give a gentle thorough massage we can give. So if we massaging means again the blood supply we are reinforcing. So in addition to that we can prevent the development of the pressure sore or skin peeling actually. So main important thing, wrinkle-free bed actually. Whenever we are preparing the bed for the patient, even occupied or non-occupied means also, especially occupied bed actually making it's little bit difficult more than the non-occupied bed. So we be very cautious whenever we are preparing the bed. Wrinkle-free bed we need to make it for the patient. Actually, as we are all know, if suppose male person without shirt we are sitting in a plastic chair or any hard surface means that marks it will be over there in our back area. Same way here, wrinkled marks it will be there on the back area of the patient. Actually, it again the chance for the development of the pressure sore. In addition to that, nail care also, especially geriatric population, their skin is very very thin. Even a single scratch means also may be the reason for the development of the pressure sore. So proper nail care and the preparation of the wrinkle free bed for these type of patient is very much important. So the prevention technique actually, I'm putting it as a short form as SSKIN. First S is the supporting surface, airbed, cushion, pillows, and all those things. Then assess the skin. Skin inspection is mandatory. Then keep moving, position changing every second hourly. I is the incontinence, bowel and bladder incontinence we need to manage. Then nutrition and hydration is the N. Actually, it's the prevention technique, short form SSKIN. So our main successful method is the engage both the patient and family because it's a contract care actually. The prevention of bed sore is a successful thing actually can do as a contract care only. We not only by the eye we can do. So we together health professional should be there for the education. Patient, if it possible, means he or she needed to cooperate with the caregiver. Caregiver need the knowledge and the caregiver have the mindset for supporting the patient. So we together only can prevent the development of the pressure sore. That thing we in introduction as itself we need to explain to the caregiver. So for that purpose, actually, if one team as like a doctor or nurse we are seeing the patient and family, we are explaining, we are demonstrating everything, we actually thinking, we educated them. But once the team is left, gradually if one doubt means they will lose the practice actually. So for that purpose actually we prepare like this leaflet actually. This is in a Malayalam form. In your mother tongue also same way you can prepare the leaflet. In this leaflet, on position after 2 hours, which from which position to which position. In lateral position means whichever the area actually needed the pillow support, whichever the area needed the cushion support, everything actually we marked over there. So any doubt means they can look this leaflet. This type of leaflet they can use it as a educational aid for the caregivers. They can you can keep it with you and you can issue to the caregiver so they can successfully they can use it. So as a part of the prevention of bed sore, I have on video. Just go through this video and we can come back. So I hope you are all go through this video. So same way by using the video or by using this type of leaflet, we can easily communicate and we can easily educate the caregiver also. I'm again repeating, not only from the our side we can prevent the development of the pressure sore. So patient and the caregiver also needed to cooperate with our education actually. So with this, I am finishing the about the pressure sore. Now we can continue with the second type of wound, fungating wound or the cancer wound. So here actually the fungating wound or the this cancerous wound, we know a sore does not heal. It's having no hope. It will cure from the patient and family side. So the definition, it's only a primary or maybe the secondary malignant growth only. It's happening on the skin, growth in the skin which has ulcerated and difficult to heal. So, especially about the fungating wound, not only the physical, other domain suffering also a little bit actually. So here also we can prepare on pathophysiology. First one may be the history, may be like this development of a skin nodule. So enlarging of the nodule, it will happen. So then gradually the disruption of the capillaries or lymph vessel because of the enlargement of the nodule. Then altered coagulation, maybe the excess blood circulation or maybe the blood clot formation. So this because of the disorganized circulation underlying blood capillaries. So it's again affecting the tissue, hypoxia and necrotic. At last, the skin it will break down. This nodule massive wound it will visualize over the skin area. So in addition to that, one more thing I'm just introducing Marjolin ulcer. Marjolin ulcer actually this is a not a new form of injury actually it's a type of malignant change is happening on an existing wound actually any chronic wound type example burn scar area or the chronic pressure ulcers venous leg venous ulcers these type of ulcers actually the ulcer is there for a while in on that actually the malignant changes it will happen this is the marginal ulcer so here also what actually was dressing the wound. The appearance of the wound is changing nowadays. Maybe some appearance of mass in the wound. Then usually normally had no pain, but newly the pain started, or maybe some changes of the exudate is coming from the wound. Actually, volume also may be increasing. Exudate volume also increasing. By doubt, suppose we doing the biopsy means at last we can rule out as Marjolin ulcer. So whichever may be means also already the fungating wound or cancerous wound or the Marjolin ulcer, we look into this actually. So here actually the fungating wound, why we calling it as a fungating wound actually? Any idea? Cancerous wound only we are calling it as a fungating wound. Why we calling as a fungating wound? Any idea? Actually, we calling not because of any fungal or any other involvement, only because of the appearance of us like fungus or us like any cauliflower like appearance. Actually, the majority of the cancerous wound. That's why we calling it as a fungating wound. So we can just go through the other domains as like a problem. First one is the physical. Physical, actually, truly the patient will have the pain, malodor, foul smell will be there, bleeding will be there, high exudate. Frequently, we need to change the dressing pad. Like that, exudate will be there, itching will be there, not only on the wound, nearby, surrounding the skin area, also having maybe the itching. In suppose unhygienic they are managing means maggots infestation chance is very high. Communication difficulty truly it will come, especially the CA buccal mucosa. Because of the foul smell or maybe the appearance of the body change, it will affect their communication also. Psychological actually they are all because of the wound actually altering their body image their sexuality and family life is affecting they are having the fear about especially the bleeding is happening means tomorrow how will be my wound how if suppose more bleeding is happen means how my family or how I can manage my wound some patients actually they are only doing the dressing for their wound actually by using their mirror they are not at all involving any caregiver for the wound dressing. In such situation, suppose some bleeding spot is coming means they are having truly they will have the fear about the bleeding in addition to that existing suffering actually. So they're having the feeling of depression and anxiety, feeling of shame for facing others, then guilt. Guilt, especially suppose the patient had the experience of using the tobacco substance now the patient is affecting with the CA buccal mucosa anything means truly they will feel guilt because of people are all advised me to stop this type of bad habits but I did not now I am suffering because of my fault only this type of guilt also actually truly affecting their psychologically Socially, actually, family isolation, self isolation will be there. By self, they will isolate it inside the family. Then later on, family isolation will happen, social isolation will happen. Example, if they are their family having small children, neighborhood also some children are also having. So normal practice, these children all are coming here and going there for playing and all those things. But later on, because of the maybe the knowledge deficit only, even nowadays also some people are all thinking this type of wound actually is a communicable thing, so they not at all allowing the children to come and go and they are for the mingling. Later on, any occasions, any marriage or any other function happening in their family, inside the relatives means also they are not at all inviting, or maybe this family only self isolation, they are all going for that. Actually, they are not at all involved with any occasion. So it's truly affecting all family actually. Their marital relation also, it's very much affecting. Spiritually, maybe spiritual means not only the religion in the spiritual component actually, but we can consider suppose the religious activity. Example, the patient is a Hindu. Suppose they are all practicing early morning, they are waking and having a bath and going to the temple. These are all some of the usual process actually doing by the patient. But nowadays, because of the wound, he is not able to go like this religious activity. So truly, it will affect their spiritual life actually. Then thinking of this one is a punishment getting from the God. In some cases, having the fear of impending death. Some person actually telling after my death, how my family exposing my body to the relatives, because maybe the CA buccal mucosa, not only because of the smell, how my appearance actually will accept by the coming relatives and other members. So these thoughts actually haunting them, not only the physical, other domain factors also, especially in the fungating wound, other factors more aggravating the symptoms as like pain and all those things. So here also again assessment, we need to assess the location of the wound actually. Any public view, suppose we can prevent means we can avoid. Example, CA buccal mucosa. We can educate to them by using the mask, or they can cover by using any shawl, anything on the dressing pad. So in somehow, if it possible means we can educate them to avoid the public view on the wound actually. Then the wound appearance, surrounding skin area, how it looks like, and all those things. Then any actually bleeding sign is there or not, all those things we need to assess. Principles actually, first one, the palliation of the symptom, pain. First of all, we need to reduce the symptom. Then our main intention, controlling the malodor or the foul smell. In addition to that, any infection means also, if anything, correct the correctable, anything needed means we need to do the management for the infection control also. Then manage the exudate. Exudate management actually, periodical dressing pad change maybe in some situation. It's only is possible. That thing we can reinforce to the caregiver. Then minimize the bleeding. We need to control or manage the pain, foul smell management, then exudate management, bleeding management also very much important. So empowering the patient and family in wound care actually, because we need to explain this wound not at all going to cure. So we can manage the wound. Our main intention, improve or manage the quality of life of the patient. With the wound itself, the patient need to live and the patient may will die with the wound. So more support actually, more empowering is needed to the patient and family actually from our side. Then from the nursing intervention or the nursing management or from the caregiver side, actually whoever dressing the patient or handling the patient, actually the intervention needed 4 5 points actually. First one, dignity centered care we need to give. First one, maintain the privacy. While doing the dressing, at least put the curtain or close the room actually, maintain the privacy, respectful communication. Even the wound, even with the foul smell, even with the bleeding, or even with the patient is experiencing severe pain, we need to respect the person actually. for the while during the communication. No negative expression because of the smell or appearance of the wound. No negative expression will see in our face actually, because majority of the patient will look into our face while doing dressing actually. I am experiencing like that only, because they are thinking if we are all feeling anything bad because of the wound, so they will look into our face. So very cautious while doing the dressing. Second one is the malodor management actually. Malodor management, something we needed to do in the wound, something we need to in the environment also. First one is the regular dressing changes. So a delayed dressing change also will cause the highly exudate and a high foul smell actually. So regular dressing change is needed. In some cases, more than 4 or 5 or 6 times needed to change the dressing pad, because that much it will soak out because of the exudate. So periodical dressing change is needed. Then odor controlling agents. I will explain in coming slide. Proper waste disposal also. Soon after doing the dressing change, actually, these dressing pad and all those things, waste material, need to remove from the room or need to remove from the patient side and discard it properly. Don't keep it inside the room or nearby the patient area. So it will affect the environmental hygiene. Along with that, emotional support also we need to give during the dressing and after the dressing, even with the while doing the communication with the patient also. First one, active listening. We will listen whichever the concerns actually patient is telling, means also we need to listen actively, because these patients concern actually they only will hide out actually later on. That much rapport with us it's having been also only they will open up. So we need to listen actively. Then we need to acknowledge their distress, provide reassurance, and any counseling is there, means we need to facilitate them for the counseling actually. Then family education. I already told we need to explain step by step. This is a not a curable thing. We need to maintain, only maintenance thing only we can do. So we need to explain about the wound and dressing technique, everything we need to tell. And if any bleeding sign means warning sign, properly we need to communicate the bad news actually. We need to communicate properly to them. So holistic approach also very much important. So while doing the dressing, actually, as like I told, holistic empathetic care we needed to do. Majority of the patient actually they are all able to move by using by with the fungating wound. They are wish to have bath, means maximum we can make them to take a nice bath before the dressing. Before dressing, thorough bath they can use do. So with the old dressing pad they can do the bathing. So that much soak dressing pad, suppose we removing from the wound, means we can prevent the development of the pain and bleeding. So dried form of dressing pad we trying to remove from, not only in the fungating wound, whichever the wound, means also dried form of old dressing pad we trying to remove from the wound, means again it will aggravate the factors like pain and bleeding. So that thing we need to keep in mind. Here actually we doing only our intention to maintain or improve the quality of life of the patient through the proper symptom control only. Curative side we have nothing can do in this fungating type of wound. So how we will minimize the pain? First of all, we know about the pain. I'm not moving, but we know nociceptive and neuropathic pain are all there. Nociceptive pain means already they are having aching, stabbing, or continuous any pain medicines, anything opioid or non-opioid or anything is there, means they can take it. So we need to ensure before the dressing proper frequent medicines they took or not. If they are missed, means give the proper pain medicine, make the symptom management pain free, then only we can start the dressing. That thing we need to keep in mind. For the neuropathy pain, actually burning or pricking type of pain they are experiencing while during the dressing or even after the dressing, if they are having any pain, means we can use lignocaine or bupivacaine. In our setting, we are all using injection bupivacaine, 0.25 percentage or 0.5%, both we are all using. 0.25 percentage means 6 ml of injection plus balance 4 ml NS. We are diluting and make it as a 10 ml. We will spray this diluted thing. We'll spray over the wound before the dressing. Keep it for 15 to 20 minutes. After that, we will do the dressing. Even after the dressing, again, patient is complaining this type of burning sensation means again we can spray this mixture diluted thing, we can apply over the wound, and we can apply the normal ointment or anything we are using means we can dress it after that. So same way 0.5 percentage means 3 ml medicine we will take and 7 ml of NS we will dilute and make it as a 10 ml. So I just told it as like a 10 ml dilution. According to the wound size, we can make it as a less quantity or more than. According to that, we can prepare. So again, I'm moving after the pain. Next one is the malodor management. Foul smell management actually daily frequent dressing pad is mandatory. Here also no betadine or nothing is needed for the wound cleaning. Hydrogen peroxide, betadine, nothing is needed. It will not help. So here actually we are using only the normal saline or homemade saline we are using for the wound cleaning. Cleaning also not by as a rubbing manner, sponge manner we are trying to make clean. So rubbing we are doing for the cleaning or scrubbing means again the bleeding chance is very high. So during the bathing means after the bath we can do the dressing, or otherwise nicely we need to soak it by using the normal saline, soak it thoroughly, then we will remove the dressing pad from the wound bed, or otherwise again cause for the development of the bleeding and the pain. In addition to that, for the malodor, injection metronidazole, tab metronidazole we are using. Massive type of wound, there is no skin folding, nothing. Example, see a breast massive wound only, no foldings or nothing means we can apply tab metronidazole powdered form. Powdered form, we will crush it without any crystal. We are very much fine powder form. We will mix it in a biolin or liquid paraffin. Make it as a jelly form or ointment form. Then after the normal cleaning, we are applying over the fungating wound, and by using the dressing pad, we can close it. So if suppose CA buccal mucosa or any skin, any folding type of cauliflower type of fungating wound means we ideally applying injection metronidazole. Avoid usage of the tab metronidazole because repeatedly during the cleaning time that much rubbing and cleaning is maybe needed for thorough cleaning out the old metronidazole powdered form from the wound actually. So we can't do because we need to prevent the bleeding. So in such situation we can use injection metronidazole also. So injection metronidazole ideally we can irrigate over the wound and clean, then we can apply spread over the dressing pad and we can close it. In addition to that, we can give the metronidazole nebulization also. Nebulization means normal nebulization kit we can take, remove the mask, only inside the chamber we can instill 3 to 4 ml of metronidazole solution. 3 to 4 ml of solution means not as a dose basis I am telling. This is a quantity only for, we need the fumes for 10 to 15 minutes the fumes, that's only. So for 3 to 4 ml we can instill in the chamber and nebulize, place the chamber near to the wound actually. So the in foldings and blind areas actually the fume molecule it will easily will go, and that's how we can control the malodor inside the wound. This is another technique. So in addition to that, any systemic antibiotic anything needed means we can start. In addition to that, same way charcoal pieces we can keep it inside the room or under the bed we can keep it. In addition to that, charcoal dressing pad is very costly, it's affordable means we can prefer. But this dressing charcoal dressing pad we are getting from the pharmacy, it's not at all affordable for the poor patient. For the poor patient actually from our Pallium India, we implemented a new thing, charcoal preparation from our side. Charcoal preparation actually here we use the coconut shells only. After the burn, the charcoal pieces it will get. We will grind it in a mixer grinder, make it as a powdered form like this. This powdered form, charcoal powder, we keep it in a steel clean container. We made it for an autoclaving. After the autoclaving, this charcoal powder ideally we using for the dressing. Not directly applying over the wound, normal wound cleaning application of thing over the wound, everything we are doing, we placing normal dressing pad over the wound. Next we will do this charcoal powder, we will mix it in a biol or liquid paraffin, then they will apply over the another dressing pad. This separate dressing pad, ideally we keeping over the normal dressing pad over the existing wound. So here actually this is an extra layer we keeping. Then we are closing. We are supposed to make the foul smell is generating from the wound itself. This layer, this charcoal layer, it's absorbing. So the foul smell is not at all coming outside. So this is way actually we are doing the charcoal preparation for the poor patient. So they are not affordable. Some new practices also I am just mentioning. I don't know in your setting anything is you are following or you already heard or I don't know, but in our setting we not at all doing, but some new practices also I am just mentioning. First one is the sugar paste, mixing of the high sugar content paste actually using on the wound actually. So it's doing it's inhibit the bacterial growth, and this is way we can control the malodor. Another one is the yogurt or buttermilk. So after the normal cleaning the wound, we can apply the yogurt or buttermilk. In some places they are applying, keep it for a 10 to 15 minutes. After that, wash it, then normal dressing we can do. So in between the pH level is varying because of the during the 10 to 15 minutes, because of the presence of the curd, this yogurt or buttermilk, the pH level is varying. Because of that, the bacterial proliferation we can control. By that way we can control the malodor. Another one is the medicated medical grade honey. It's also it's using, it's a high osmolality characteristics is there. So this also inhibit the bacterial growth, and because of that way we can control the malodor inside the wound. These are all some of the practices in some places are all doing, but we never practice. So I already told some order controlling management things also we can do. That thing coming under the odor concealers or aromatics. Aromatics actually from the outside, environmental only we are doing. For that actually we can use the essential oil. Essential oil means some oil I am suggesting peppermint oil, wintergreen oil, lavender oil. So these type of essential oil not be applying directly or nothing on the patient body. We are soaking in a cotton ball, and soak the cotton ball we are keeping on the bed only nearby the patient area. So this having not much smell as like any wood or other, nothing, but such a natural smell, it breaking down the foul smell actually truly coming from the wound. So this is all some of the way we are trying to make break the development of the malodor from the wound. These are all the management side only, because these are all the way, through this way only we can manage the malodor. So another one, pain, malodor. Third one is the bleeding. Bleeding actually we can prevent. I already told, with the thorough soaking only we can remove the dressing pad from the wound. Or otherwise, truly the patient will feel the pain. Second one is the bleeding. Chance is very very high. During the dressing also we can sponge manner only clean the wound. Don't rub over the wound. Actually, it will lead to the development of the bleeding. So if normally the sweating type of bleeding, the chance is very high, and during the dressing time. So apply a local pressure over the area. Through this way we can control the bleeding. Suppose more profuse bleeding is happen means we can use the tranexamic acid, any systemic ethamsulate usage, IV or anything is needed means we can do. Again here also we can apply. Initially we are all using sucralfate powder. I think now we are not at all getting, it's not available in our setting, sucralfate powder. In your side I don't know if it have means. By using the sucralfate powder, same way, mix it in liquid paraffin or biolin, make it as a paste form, we can apply over the wound. Same way ethamsulate also we can do. Ethamsulated tablet, crushed form, we can mix it in the biolin or liquid paraffin, then we can apply over the wound. This also it will control the bleeding. In addition to that, actually Tranex or systemic ethamsulate is needed means we can do. If anything, any role by using the palliative radiotherapy for the bleeding control, to improve the quality of life, means only we can proceed or we can facilitate for the palliative radiotherapy or leave it. Then dark colored cloth, we need to educate, we need to empower the, as a part of the empowerment of the patient and family, make them to understand the importance of keeping the dark colored clothes nearby the patient. Actually, maybe the patient will end up because of the profuse bleeding. This is the actual that maybe will happen. So the family needed to prepare by themselves. So we need to educate to keep. Then any cancer therapy role is there, means only we can proceed. Otherwise, leave it from everything actually. Finally, I'm telling about the maggot infestation. Unhygienic practice of keeping the wound or cleaning the wound actually leading to the development of the maggots. So proper covering the wound by using normal clean dressing pad, frequent dressing pad change. If once the flies is getting inside the wound or laying it, means surely the maggots it will develop. So we need to keep in mind, once the prevention is the better management actually here. So maximum covering the wound, the importance we need to explain. In some cases, some old peoples actually they are open by their wound. Actually, they are all feeling fresh air is needed for getting cure this wound actually. So during this time, maybe coastal area or environmentally unhygienic area, means flight should be there, especially inside the patient room also. Food particle, any other humid environment, everything we need to prevent, or otherwise surely the flies it will be there during the dressing or later on it will come over there, and because of that the maggots infestation chance is very high. So that thing we need to communicate. Proper hygiene is very very important. Once the maggots is happen, means we can use the turpentine oil, not directly sponge it in a gauze piece or the dressing pad, keep it nearby the wound actually. Because of the turpentine oil, the smell, the maggots it will come out. Manually we can remove and put it in a hot water, uh, actually boiled water. In addition to that, one practice I am telling, maybe this maggots in a normal fungating wound, means okay, we can use the turpentine oil for the removing the maggots. But the once the maggots is happen some tract area, example vagina or rectum, any such type of tract area, suppose the maggots is infested, means with the turpentine itself we can't, maybe continuously we can't manage. So such areas in some setting actually they are applying vegetable oil, coconut oil or some oil they are applying over the wound. Because of the oil appearance, lack of oxygen supply, the maggots is naturally will come out. Such way we can remove the maggots. So these are all some of the things we can do for the maggots infestation also. So thank you, and I'm completing my topic actually. If any doubt, means quick questions, you can share, you can put it in chat box.
Thank you, Sajan brother, for that extensive presentation. I think we have one question in the chat box, if you can take up that. Dr. Shobha was asking how to manage an 85-year-old patient with stage 7 biliary lymphedema with recurrent admission due to losing and fever.
So actually, lymphoria.
Dr. Shobha, would you like to unmute and clarify?
The patient is having, because we cannot do his work because of this, and because of this foul smelling. Every time there is continuous oozing and getting infection.
Okay.
So what to apply, what to...
Normally, ma'am, lymphoria wound actually maybe it's infected, means systemic infectious managements we can do. In addition to that, foul smell management, same way, which are all things actually we shared here, same way we can do over the area, but proper guidance and treatment is needed. then the caregiver support also very much needed, because periodical changing of dressing may be mandatory, because lymphoria completely wetting always.
It's
So
always wetting.
yeah. So it's a difficult situation, but periodical dressing change is needed actually.
Thank you. Should he apply any antifungal agents or?
No, actually, antifungal not at all needed actually. Is it needed means only maybe near to axillary area. Any fungal infectious sign is there means, otherwise no need.
Thank you, Brother Sergeant. Dr. Adra wants to know if you are applying charcoal patch, how frequently it should be changed.
Same way, actually, ma'am, same way, whichever the time. Example, we are doing the BD dressing change means every dressing time we need to take a new one. That's only. BD dressing, suppose we are doing for the wound means dressing time we need to change, prepare a new charcoal dressing pad and for the patient. Actually, we are not at all concerning about the charcoal layer. We concerning about the wound. Frequent dressing pad change for controlling the exudate actually. More exudate is wetting and keeping for a while means nearby the skin area also affecting actually. Nearby skin health also very important. Not only about the wound.
The next question is from Dr. Preeti. Can talcum powder or antifungal powders be used over the back for massaging as I see filler?
Actually, ma'am, for the prevention of bed sore, we are ideally telling talcum powder, no powder actually we supposed to using, because the point is it's again getting dry for the skin. So more comfortable and more effective thing, application of the moisturizers. Fragrant type of moisturizer are available, but it's giving only the fragrance. The moisturizing effect, it will not last for a long time. So it's a very cheap item, white petroleum jelly, having no smell but moisturizing effect. It will long lasting more than the these type of costly fragrant item. Especially we are all thinking about the poor category people also, so they are affordable about this and effective also.
Next question is how do we look for tunneling and what instrument can be used?
No, ma'am. Actually, dressing time means by using artery or maybe by using any swab we are using, only for whichever the clockwise direction the tunnel is there or not. According to that, maybe packed dressing may be needed. That's why.
Next question is from Dr. Sara. Does hydrocolloid dressing or local phenytoin helpful for wound?
Yes, according to the stage wise, according to the wound development ways, we can do not only the traditional dressing pad, some other hydrocolloid, then foam type of dressing, colloid dressings are all available. But the scenario is it's a little bit costly than the traditional dressing pad. So the poor people can't afford all those things. If the patient is affordable and it's needed according to the patient that wound stage, it's needed means we can continue and we can do.
Thank you, Brother Sergeant. I think we do have a case, but only 10 minutes left. So, do you like to take up the case quickly or?
Is it possible to finish? I think
Uh,
this case, I think related with some surgical wound.
hmm.
Actually, our topic is pressure sore and fungating wound.
Sure.
So I think the presenter, I am respecting them. Doctor, actually, you need any clarification actually. Making to putting us a discussion point from the case scenario now means you can just note it and we can discuss. Keep the discussion we can do.
But Dr. Indurani, it's your call. So anyways, we will have to wind up at 6:30. We need to keep up the time. So do you want me to quickly share the case or just ask Dr. Indurani to ask her queries if she has any? And then maybe we can upload the case later to the platform for everyone to access. Are there any quick other questions which we can take in related to this topic?
Yes.
Okay, so we can just quickly brush up the case once, Dr. Sajan, and then we can see if
Okay.
we can wind it up. Dr. Indurani?
I'm audible?
Yes,
Hello.
now you are.
Yes, you are.
So you can quickly just go through the case and let us
Hmm.
see if we have time
I'm
for discussion.
Okay. I'm Dr. Indrani, working as a medical officer in TVS Lakshmi Hospital, Madurai. Today I am presenting a case of surgical site infection wound. A 73-year-old next slide. A 73-year-old male living in a geriatric care center had an accident for 1 month prior and sustained fracture right neck of femur, for which he underwent ORF. Now he presented with discharge from such site 3 days, accompanied by high-grade fever with chills and rigor 3 days. Patient discontinued antibiotics and returned to home and now come with the above complaints. Comorbid hypertension on treatment. On examination, general examinations, vitals are stable. Pulse rate 102, respiratory rate 22 per minute, BP 130/80, SbO2 96 yeah. So he was febrile, 101-degree temperature and failure. On local examination, in this way, a vertical scar over the right lateral hip region extending to the thigh. A small wound gapping at the upper end of the incision site. A linear wound gapping over the thigh level. It is 7 into 1.5 centimeter. The underlying tissue was exposed with slough, full and discharge noted. Edema surrounding the wound also noted. Treatment and symptomatic investigation, routine investigation done, hemoglobin 7.4, total count 16,300, and platelet count is 1.4. CRP is highly elevated, 195.3. Renal function test, urea 22.9, creatinine 0.9. Serum electrolytes are normal. First culture, heavy growth of MRSA. So, in psychosocial concern, depressive look, lack of social interaction, not cooperative for twice daily dressing, refusal to eat, poor and sleep. Psychosocial aspect involved in treating this patient, lack of social support because he is living in a geriatric home center. No motivation, absence of knowledge about the underlying disease, no follow-up with the primary physician. Then, how was the wound managed? To improve the general condition, then wound management. Improving the general condition, nutrition, addressing the sepsis, mobility, physiotherapy, providing psychological support. About the wound management, provide comfort, manage the symptom, pain and exudate, etc. Preventing complication, because in this case, process is infection in our case, in this case. So first, we are bedside dressing, then debridement under anesthesia, vacuum dressing, then secondary suturing done for this patient. First, plastic surgeon opinion obtained. So septic control, we give injection leading up to 600 milligram IV BD and dialysis 300 milligram BD. And psychiatric support mean psychiatric opinion obtained because patient on admission very depressive. So after the psychiatric opinion only, patient was cooperating with us. Psychologist counseling once in 2 days are given. Psychiatrist he give antidepressant. After that, we will follow our treatment. Then pain management, injection paracetamol 1 gram IV, SOX, and buprenorphine patch application also given. Then what is, okay, okay. What is NPWT? Negative pressure wound therapy. What is that? Back assisted closure. Why NPWT in this patient? It is post-surgical exudative wound, regular daily dressing carrying a risk of sepsis and sterility issues, and can add more discomfort to patient. Deeper wound with prosthesis in situ, back helps in earlier and faster granulation tissue formation. In this picture, post-wound debridement after back application picture is here. In vacuum assisted closure, there is a 4 part. One vacuum pump, special bandage, a canister to connect the fluid, and a tubing. In vacuum therapy, also called negative pressure wound therapy, NPWT, it applies a controlled vacuum to the wound to create a sub-atmospheric pressure environment. This is achieved by placing a foam or gauze dressing over the wound, sealing it with a transparent thin film, and connecting it with a vacuum pump via tubing. The vacuum removes excess fluid, reduces the swelling, and help draw the wound edge together, promoting tissue growth and healing. In the mechanism action, it promotes granulation tissue formation, stimulates the localized blood flow, reduces the bacterial colonization, provides moist wound healing environment, reduces the localized edema, enhances the epithelial migration, applies negative pressure to the uniformly draw wound closure. The vacuum dressing indication and contraindication are the vacuum dressing is suitable for diabetic foot ulcers and pressure sores, burns and crush injuries, post-surgical wounds including sternal and abdominal lesions, skin graft fixation, traumatic wounds, and large soft tissue defects. It is particularly useful for wounds that have failed conventional treatment or carry a high risk of infection. But VAC therapy should not be used for malignant wounds, untreated osteomyelitis, wound with the necrotic tissue, exposed nerves, arteries, and vital organs, then fistula. Summary. Patient was started with IV antibiotics, regular dressing, and other supportive treatments, and 2 units of Paxil transfused. During the hospital stay, pain management done with the injection paracetamol, 1 gram IV SOS, and buprenorphine patch. Antidepressant, Q-tip 2.5 milligram started. In view of persistent discharge from the wound site, plan for debridement under anesthesia. Later, back dressing applied due to poor cooperation by the patient for regular dressing. After a week, second suturing was done, wound healed well, and he was discharged in stable condition. Facts regarding the back. Ideal for deep wounds, complex wounds that are not healing. Ideal pressure to be maintained by minus 125 mm. It will accelerate granulation tissue formation by 60%. Thorough debridement of the wound bed is advised prior to the back application. Correct application by trained personnel is needed for optimal outcome. Take home point, patient comfort, aggressive tissue healing. Never wound management option to be considered over conventional dressing. Risk of early or delayed implant infection, as in this case, to be kept in mind in patient with in situ processes. Overall, choreostatic support is crucial in better outcome. Nutritional, psychological aspect to be given importance. Risk assessment is vital in wound management to rule out the underlying medical disorders, diabetes or peripheral arterial occlusion disease, and nutritional status. Thank you.
Sajan, there was one last question I guess in the chat. From Dr. Sajan. I have seen a skin-colored bandage applied to possible pressure sites like heels and sacrum in tertiary care hospital for prevention of pressure sores. What is it? Is it costly? Is it effective for prevention?
Actually, this one that was maybe the foam type of dressing pad. Foam type of dressing pad actually using only on the pressure prone areas, not on the wound. I think from the stage wound itself, not at all skin peeled off, non-blanchable erythema sites, bony prominent areas. We are supposing this foam type of dressing pad we using means it will give a cushion effect over the area. So further skin peeling we can prevent.
Any participants have any questions related to Dr. Indurani's presentation, or Dr. Indurani, you have any questions, quick questions which you need to take up with the faculty?
No, ma'am. Actually, metronidazole ideally we are preferring. It's very cheap and it's very effective. From our experience, we are sharing this idea, metronidazole usage, very cheap and effective. So this having no healing power only for the foul smell management. For a while we are using, after once the controlling the foul smell, we again going back to the normal dressing. Anesthetic spray, I have no experience, no other thing. We using the bupivacaine thing only. I already told about the dilution and usage. We experiencing like that only.
Oral carcinoma, foul smell.
Oral carcinoma, I think we can't trust it. It's a very little bit difficult situation. But periodical oral gargling by using homemade saline, prepared homemade thing, they can use it for periodical gargling. They can use it. Further,
Any other questions? Shall we wind up for the day? Okay, I think we can call it a day, Brother Sajan. Hope I'm audible.
yes.
Okay. So thank you, Brother Sajan, for joining us. I know you have had a very busy day with a lot of observers in the Parliament premises. And still, you found out time to join us and you shared your expertise and knowledge with us. Thank you so much for that. And thank you all the participants for sharing your queries and comments in the chat box. And thank you so much, Dr. Indrani, for sharing your case. And till the time we meet again, this is Sri Priya along with Brother Sajid signing off from the Parliament Desk. Stay connected, everyone. Keep spreading happiness around you. Take care. Bye bye.